evening, everyone. I'm Dr. Alpana Awasthi. I'm an associate consultant at Gleneagles Hospital, Mumbai. My topic for today I would be sharing with you is electrolyte imbalance in surgical patients. Okay, so we'll deal with all pre-operative, intraoperative, and post-operative scenarios. All three, which are a part of a surgical patient's schedule. So first of all, our topic is electrolyte imbalance, but it would be wrong to say that electrolytes do not go hand in hand with fluids. So we have to discuss the fluid balance and imbalance along with electrolyte imbalance. So fluid and electrolyte balance are the most important aspect of any surgical patient, whether it is an elective patient or it is a emergency patient. So fluids have to be in control with the electrolytes. If there is any disbalance, then a surgical patient can have very bad post-operative outcome. So now, first of all, we will discuss we're starting from the fluid. What is the fluid balance in our body? In a normal human body, for a male, total body water content is about 60% of the body weight in young adult male and 50% in a young adult female. So solids are 40% and water content is 60% in a general male I am talking about. Out of this total body water, 2/3 is intracellular fluid, whereas remaining is extracellular fluid. There's a cell, every human body has one cell. So there is an extracellular fluid and there is an intracellular fluid. Now, sodium and total body water, they are mostly, they are permeable in intracellular and extracellular. That's why you can see the arrow, over there. Now, the extracellular fluid is also divided into two compartments. That is, 1/4 is extra, or 1/4 of the extracellular fluid is the intravascular fluid. That is wherein the colloids and the RBCs are there. Water is there everywhere. Then 3/4 of the extracellular fluid is the interstitial fluid. Okay, that is besides all the colloids, RBCs and all. So this is the whole scenario. Now, why in a surgical patient why do we learn this? Because we have to monitor the surgical patients in that fashion, be it pre-operatively or post-operatively. Because any surgery, whether it is general surgery, it is a urological or it's a neurological surgery, there is a quantification of the urine pre-operatively as well as post-operatively, plus the feces pre-operatively plus post-operatively. So what is this fluid intake? So fluid intake it can be water from the beverage and it can be water from the food. But last is the endogenous, that is oxidation of solid foodstuffs. So this is the intake, which can be beverages, can be 200 to 300 ml in a particular day for a normal human being without any disease condition. Water from food can be 1000 ml. So basically beverage and food, anything, like that, around 1200 ml. Water from oxidation can be 300 ml. But the excretion is also in the systematic way, that is urine can be 1500 ml per day. Insensible losses like losses from your skin, that can be around 900 ml, and losses from the motions, that is the feces, it can be 100 to 150 ml. This is important. This is the tabular form of a normal individual. So fluid loss by 4 routes is lungs, by skin, as I told you, feces, urine. So now from the lungs, it can be as like 400 ml per 24 hours. So why in some surgical patients like who are in ventilator, who are on tracheostomy, you have to get them humidified. Why? Because there is a loss of fluid even through the tracheostomy, through the lungs. Your skin, your sweat, it is around 600 to 1000 ml per day in a normal temperate climate. Your motions, there are 60 to 150 ml of water, normal bowel motion. When a patient is not obstructed, is not in any kind of any perforation or anything. Urine, it is normally 1500 to 1600 per day when the kidneys are healthy. There's no CKD patient. So this is a normal individual. Now first, I would like to give you a brief idea about the fluid therapy. Fluid therapy in surgical patients. What are the fluid we give in normal surgical patients? So proper fluid, and then I would discuss you the electrolyte part of it. Proper fluid and electrolyte state is helpful in reducing the morbidity and mortality in surgical patients. Many factors are to be considered in analysis for proper fluid and electrolyte balance in a normal post-operative surgical patient. Why we do the electrolytes pre-op and post-op? Why the anesthetists demand that? Why we see the potassium? So here will be the answers. Fluid therapy in surgical patients can be discussed as pre-operative, intraoperative, and post-operative. Now, factors affecting the fluid and electrolyte balance. So any emergency patient or even a normal patient can come in a lot of stress. He's got a surgical stress. How is my surgery going to be? How I'm going to fare in the surgery? Whether it will be proper or not. So there is an increase in the sympathetic stimuli. There is a tachycardia. You must have noticed the patient is in a recovery. Everything is okay. It's an elective surgery. It's a normal surgery. It's a swelling surgery. But the patient can have tachys. Pulse can go to 90s. BP can be raised. So these are all the vasoconstrictive responses because of stress. So body reacts to it. Increase in ACTH hormone stimulates the adrenals to secrete hydrocortisone to fight now there is a response mechanism to fight acute stress. Aldosterone is released, which leads to sodium retention. Now see, body is going to react as God has made us, as the nature has made us. So it is going to react, whether he does not know whether this is a normal surgery or another surgery, he is going to react. Obviously, in an emergency surgery, these responses will be way before. But in an elective surgery, they can start it from the recovery period itself. So this can lead to sodium retention and urinary loss of potassium. Major surgery, there is a hypovolemia. So patient is coming in obstruction, patient is coming with blood loss, hemoperitoneum, there is a hypovolemia. There is increase in aldosterone for 2 to 3 post-operative days. The body takes time to recover from that acute stress. So there is decrease in sodium requirement. Why? Because the body has already retained sodium a lot. Post-operative pain, that pain can cause stress. They can cause an increase in ADH secretion. The pituitary gland, it gets a signal, we have to secrete ADH. So there is water retention, reduction in the urine output. Urine output can be as low as 500 ml in post-op per day. Without being any complication in a surgery, it can be normally also like that. So we have to know these factors. So in fluid deficit, pre-operative, you have to resuscitate the patient. Any patient who is coming fasting to our surgery, suppose he's fasting from the night. If we are taking him in the morning in the surgery, then it's another thing, 8 hours fasting. But if we are taking him in another 8 hours, then the patient needs to be under fluid therapy. So he needs replacement pre-op or intraoperatively. Abnormal blood or fluid loss needs proper calculation for rate of fluid to be infused. Hypovolemia to be corrected prior to surgery. Otherwise, surgical stress or direct damage can affect the kidney, the lungs, the brain, skin, GI tract. These organs are useful in maintaining the fluid electrolyte. Just I told you, there can be insensible losses and acid-base balance can be disturbed. Then we have the pre-operative fluid therapy in surgical. How is the correction of hypovolemia?